previous class we had discussed about various breast diseases, in that normal anatomy and other diseases like proliferative and non-proliferative breast diseases. Then we started discussing about breast cancer. In that we have discussed about carcinoma in situ, that is non-invasive type of cancer, and now we are discussing about invasive carcinoma. So this is the most asked question regarding breast cancer. So invasive carcinoma is classified into two types basically. The one which is not a special type, and this is the most common type. So 70 to 80% of invasive cancer is of not a special type, that is a typical ductal carcinoma. Okay, and the other classification being invasive carcinoma of special type. In this, all other types like invasive lobular carcinoma, colloid carcinoma or mucinous carcinoma, tubular carcinoma, and other carcinomas are included. Till 2019, carcinoma with medullary features was also included under special type, but since 2019, WHO has included this carcinoma with medullary features under not a special type. Okay, so not a special type is most of the cancer, breast cancer, that is about 70 to 80%. Rest comes under special types. So yeah, what is the pathology behind invasive cancer? That is, usually there will be a precursor lesion like ductal carcinoma in situ or lobular carcinoma in situ, which will eventually grow on, invade the basement membrane, and then become invasive, and hence will lead to invasive cancer like typical ductal cancer. Okay, so coming with invasive ductal carcinoma, which is the most common type. So invasive ductal carcinoma is usually on gross appearance, it appears like a crab. So if you have taken a cross section of a breast specimen, entire thing will be filled with fat, and usually there will be invasion of a tumor which will be spreading like wherever possible. So usually this appears like a crab. Okay, so hence it is said that usually this will be whitish in color. So white, greasy white structure, which is usually a grit-like substance or a solid tumor, which will be arising in the specimen of breast, is typically invasive ductal carcinoma. So on gross appearance, it is like a crab. So what will be the clinical feature? Usually it presents as a palpable mass, and it can go on developing, and there will be other clinical features like there will be retraction of the nipple or powdery orange appearance, and extensive ulceration can be seen. Okay, so on microscopy there will be pleomorphic cells. Pleomorphic cells meaning there are various types of cells in various stages, not just a single type of cells. Okay, so based on these features we can identify it as a invasive ductal carcinoma, okay, by gross and by microscopy. After this, grading is done by a system or grading system called as Bloom-Richardson grading system, also known as Nottingham grading system, which basically grades based on the visualization, like if there is a tubular formation or if there is a nuclear pleomorphism or a mitotic counts. These are all again a pathological grading. Okay, so based on this, each this thing is given a grade score of 1 to 3 and maximum of 9. So under this, it is classified as grade 1 tumor or grade 2 tumor or grade 3 tumor. So grade 1 tumor is usually well differentiated, grade 2 is moderately differentiated, and grade 3 is poorly differentiated. So based on this we can judge the prognosis and treatment. Okay, hence this grading is important. Okay, so this was about invasive ductal carcinoma or typical ductal carcinoma. Okay, after this we are coming to one more new classification or new carcinoma which is included under not special type, that is medullary carcinoma. Okay, this is usually associated with BRCA1 mutation. BRCA1, we all know it is a anti-apoptotic gene. Okay, so when it gets mutated, there is a hypermethylation of BRCA1 promoter. So this brings down down regulation of the BRCA1 expression. Because of this, cells won't die, so there will be cancer. Okay, so usually it is seen in 45 to 54 year age group, and it presents as a well circumscribed mass which usually mimics benign lesion, that is fibroadenoma. So we can confuse this medullary carcinoma with fibroadenoma because it usually mimics benign lesion and it is a well circumscribed mobile mass. So we should keep this point in mind in order to differentiate it from fibroadenoma. Usually the tumor is soft, pale, grey and fleshy on gross appearance with medulla as a center of tissue. On microscopy, there will be usually sheets of cells which are also called as syncytium of cells, and intensive lymphoplasmacytic infiltration can be seen in case of medullary carcinoma. Most of this is related to pathology. Okay, so this, in order to understand the surgical treatment, we need to know in detail about the pathological classifications and pathology. So I am taking in-depth pathology so that when we deal with proper surgeries, it will be useful for us. Okay, so now coming to other special types, usually have specific genetic signatures. So coming to lobular carcinoma, these have usually biallelic loss of expression of CDH1 gene. So if this gene doesn't express, there is not a protein formation won't happen. That is, that protein is E-cadherin. So this helps in adhesion between the two cells. Okay, so since there is loss of this CDH1 gene expression, there is decreased E-cadherin expression. Because of that, there will be discohesive cells and they are invasive. Because of this reason, they will be like arranged in a line like this, and this is called as Indian file pattern. So the tumor cells will be arranged in this pattern, and hence the name Indian file pattern. These are not adherent to each other, but they are arranged in a single line. Okay, that is a specific genetic signature in case of lobular carcinoma. If you see the cells arranged in a single layer in microscopy, then and you are able to differentiate it, like it is arranged in a single line, it is in the form of a Indian file or single file pattern, then it is lobular carcinoma. Usually there can be a signaturing appearance also, like nucleus will be pushed to the periphery and most of the things will be filled with mucin or fat. Okay, so that signaturing morphology also classifies it as lobular carcinoma. And there is no duct formation because E-cadherin mutation is there. So it can also spread metastatically to peritoneum and retroperitoneal structures, or to meninges, or to GIT, ovaries and other uterus. Okay. Now, what are the other types of special type of breast cancer? Invasive carcinoma, that is luminal cancer, HER2 cancer, TNBC. Okay, triple negative breast cancer. Okay, so other types, luminal cancer is lobular carcinoma, mucinous carcinoma, tubular, papillary. Just remember the names, that's enough. So HER2 cancer being apocrine and micropapillary, and triple negative cancers, these are having poorest prognosis. Hence, these should be remembered. So among all this, invasive inflammatory breast cancer of medullary type is important. Okay, so this was about invasive carcinoma, that is of special type and not of special type. After this, we need to know how does this breast cancer spread. So breast cancer can spread directly or through lymphatics or through hematogenous route. Okay, so directly it can spread to skin, areola, nipple and chest wall, that is the surrounding tissues over there. After that, lymphatics, it can spread to axillary lymph nodes, it can spread to internal mammary lymph nodes or to supraclavicular lymph nodes. Hematogenously, it can spread to lungs, liver, brain and bone. So hence, breast cancer should be diagnosed as early as possible and treated as early as possible, because it has various routes of spread and can spread to entire body. Yeah. So what are the prognostic factors that determine the treatment for breast cancer? That can be lymph node metastasis. If the breast cancer has metastasized to axillary, internal mammary and supraclavicular lymph nodes, prognosis is poor. If it is limited to one or two lymph node, group of lymph nodes, then prognosis is good. Similarly, if it is inflammatory, then again poor prognosis, because it is a triple negative breast cancer. If there is distant metastasis, poor prognosis. So again, this depends on counseling, like what if the patient understands the pathology of the disease well, then she can opt for a better choice of treatment, and clinical trials will be possible because of this. Okay, so all these factors determine how easily we can treat and cure the disease. Okay, coming to treatment of the breast cancer. So this is the most important part, because we are dealing with surgery. Okay, so before starting, why should we treat? What is the goal of treating the breast cancer? So in treating a breast cancer, our main goal is to control the local disease and to prolong the survival by treating metastasis. So these two are the main goals. One, if the disease is local, we have to control that local disease, and we have to ensure that the patient is surviving for longer duration in spite of metastasis. So in order to control the local disease, we can choose breast conservative surgeries and radiotherapy. Most of them will opt for prophylactic mastectomy. Okay. In order to prolong the survival, we can go for systemic therapy like endocrine therapy, chemotherapy, targeted therapy. Like for HER2 positive cancers, we can go for Herceptin or HER2 inhibitors, these drugs. And for ER positive, specific drugs for that. So based on this, we can control the disease and prolong the survival by treating the metastasis. Okay, so we will discuss this in detail after a while. We'll just finish off stromal tumors. So since yesterday we are discussing about epithelial tumors or epithelial diseases, right? So what was the other thing? What was the other component of breast? It is stroma. So if the tumors arises from this, then they are called stromal tumors, and among them the most important ones are fibroadenoma and Phyllodes tumor, which arises from stroma. So this can be again classified as interlobular stroma or intralobular stroma. So again we will have to resort for the anatomy. So whatever the stroma is here, this is interlobular stroma, and again lobule consists of a certain region, and whatever the stroma is there within that lobule, that is intralobular. Okay, so again the same old classification. Interlobular, most common diseases are angiosarcoma, which is a malignant tumor, lipoma or myofibroblastoma or fibrous tumors. Okay, so intralobular being fibroadenoma and Phyllodes tumor, these two are the most important ones. So what exactly happens? Whatever the growth factors are there, they will usually stimulate stroma, and because of that, stroma and non-neoplastic epithelium component will be there. Usually there is associated mutations in MED12 gene. Okay, this leads to fibroadenoma and Phyllodes tumor. Okay, now we will discuss both of them individually. So fibroadenoma, this is the most common benign stromal tumor, usually seen in young reproductive age females, and 2/3 of the disease or 2/3 of fibroadenomas is associated with MDM12 gene, and clinical features usually solitary freely mobile lump will be seen, and it is also called as breast mouse because of its high mobility. It can be multiple and bilateral also, and it is usually hormone sensitive. Those who are having high estrogen, they are usually found to have fibroadenoma. On microscopy, what are the features? It contains a mixture of both epithelial and stromal tissue. Just like I said, stromal component will contain fibrous tissue, and epithelial component includes duct lined by double layered epithelium, that is myoepithelial cells and luminal cells. So since the stromal component is a fibrous tissue, based on that, again fibroadenoma can be classified as intracanalicular or pericanalicular, wherever the stroma is deposited, that's it. Stroma presses the ducts and this creates slit like spaces, whereas pericanalicular loose connective tissue around the ducts will be seen. This is not much important, just remember fibroadenoma clinical feature will be a solitary freely mobile mass, and it is also called as breast mouse, and usually it contains both stromal tissue as well as epithelial component. Yeah, other classification of fibroadenoma being juvenile fibroadenoma, which is seen in young adolescent females, and there is a history of rapid growth, like in 1 or 2 days only they will be saying like before 2 days there was no lump, now I am feeling a lump. So rapid growth will be there, and usually there is hyperplasia of stroma and epithelium both. In case of complex fibroadenoma, there are fibrocystic changes which is a risk for malignancy. Okay, so giant fibroadenoma, again it is a massive sized tumor which is of more than 10 centimeters. Okay, so this was about fibroadenoma. Again, what is the treatment? Treatment is just simple excision. Okay, next one being Phyllodes tumor. So this is called Phyllodes tumor because it appears like a leaf like tumor on microscopy. Okay, so this arises from the intralobular stroma. Again, majority have MDM12 gene mutation, and it can become malignant. So MDM12 gene and telomerase encoding gene mutation, third gene mutation will become malignant. So unless and otherwise it is benign tumor. So on my gross pathology, it appears like a large tumor which is bulbous protrusion, and these protrusions usually extend into the cystic space, and they have whorled pattern with cleft-like spaces that resemble leaf buds. Hence the name Phyllodes tumor. On microscopy, again, these will be exaggerated intracanalicular growths like fibroadenoma only, but there are leaf-like dilated lumens. These usually have high mitotic rate, stromal overgrowth, high cellularity, and all. Okay. So again, these are graded as low-grade Phyllodes tumor or high-grade Phyllodes tumor. Uh, Low-grade Phyllodes tumor are usually benign, but high-grade are malignant. Okay, what are the risk factors or complications? It has high recurrence. Even in spite of excising it, there is high chance of recurrence, and lymphatic spread is not so common. Okay, it usually spreads through hematogenous, so uh, we won't be able to identify it unless basically it is delayed identification only. Delayed diagnosis will be done in case of Phyllodes tumor. Okay, now coming to surgical procedures. Just like I have told you before, breast conservative surgery plus radiotherapy. This is our main goal in order to control the local disease. Okay, so under breast conservative surgeries, we will go for mastectomy. So in mastectomy, there are various types of mastectomy. That is, we'll study it one by one. First one being total or simple mastectomy, in which we are giving a horizontal incision or a coccus incision or a green rough incision or Stewart incision. Basically, simple mastectomy means just removal of breast. Okay, so total mastectomy with axillary clearance. This includes total mastectomy, that is removal of breast. Along with breast tissue, we are removing level 1, level 2 and axillary fat, along with that axillary fascia. These are level 1 and level 2 group of lymph nodes, along with that axillary fat and axillary fascia, hence the name axillary clearance. Next, coming to modified radical mastectomy. This is performed most extensively in our colleges and hospitals usually. Modified radical mastectomy. Again, there are three various types like Patai's modification, Scanlon's modification, Auchincloss modification, based on how they perform the surgery. We'll deal with it later on. Okay. So, what is the procedure exactly? How do they perform this modified radical mastectomy? Usually, elliptical incision is made from the medial aspect of second and third intercostal space, enclosing the nipple and areola tumor. Okay. So, if this is a breast, this is a nipple. Usually, they put a elliptical incision this way. Okay, so that is what they are saying. Usually this is at the second and third intercostal space. So this includes nipple areola, and if the tumor is growing here, it will include the tumor also, enclosing the nipple areola and the tumor. So this incision is extended laterally till the axilla along the anterior axillary fold. Okay, upper and lower skin flaps are then raised, and then breast with the tumor is raised from the medial aspect of pectoralis major muscle. Dissection is proceeded laterally, ligating the pectoral vessels. Lateral border of pectoralis major is cleared with level 1 lymph node. Other than that, pectoralis minor is divided from the coracoid process to clear level 2 lymph nodes, because we know level 2 lymph nodes is situated just posterior to the pectoralis minor muscle. So here, based on this, like what modification or what step we do in this, it is divided as Patai's, Scanlon and Auchincloss. If we cut the muscle and remove the level 2 lymph nodes and we join it back, it is Auchincloss. Okay, so such are the modifications. If we excise the pectoralis minor muscle also, then it is Patai's. Also similarly, okay, there are certain procedures like that which lead to these modifications. Okay, and then medial pectoral and lateral pectoral nerve are preserved. Then level 3 group of lymph nodes are cleared. Then the wound is closed and suction drain is inserted, and then closure is done. Okay, so this is a procedure of modified radical mastectomy. Basically, we are removing breast tissue, that is total mastectomy, plus level 1, level 2 and level 3 group of lymph nodes. Along with that, the tumor is also released. Yeah, so this is a procedure. Here, medial pectoral nerve and lateral pectoral nerve are preserved. Pectoralis minor muscle, again it is left to you. Okay, if you want to preserve, or I mean what type of method you are following, based on that you can do the surgery. Next, coming to wide local excision. This is also known as partial mastectomy or lumpectomy. Here the incision is made directly over the tumor and the pectoralis fascia is not opened, unlike in total mastectomy. Here the specimen is marked after placing in orientation grid and then mammography is done, followed by frozen section biopsy to look for clearance. Okay, at least 1 mm clearance is needed for adequacy. Then after the clearance, then the excision is closed cosmetically. Okay, there is no drain placed. Along with wide local excision, separate axillary dissection is done. Then radiotherapy to breast and chest wall is given. Okay. So basically, what is the difference andre? If you know that this is a tumor, you will put incision directly over the tumor, you will excise it, and then with the patient on table, you will send the specimen for frozen section. So once the frozen section is done, they'll say if there is a margin, if this is a tumor excised, in the section, frozen section itself, we will come to know if there is a positive margin around 1 mm or not. If like with the tumor we have given, if there is less than 1 mm clearance, like there are no tumor cells after 1 mm, then it is said that okay, clearance is obtained, then the excision is closed. Okay. So after this, again separate axillary dissection is done. After that, again radiotherapy is given to breast and chest wall. Okay. So this is another type of excision called as wide local excision. After that, again one more procedure is toilet mastectomy, which is done usually after chemotherapy. So first chemotherapy korthivi. Once the tumor has regressed, then in order to prevent the further fungation, we will just remove whatever the tissue is possible. Okay, this is a very dirty surgery we can say, because usually fungation would have happened. We can't do anything. Just in order to clear whatever possible, we will do this surgery. Hence the name toilet mastectomy. Okay. Other one being skin sparing mastectomy. It is also called as keyhole mastectomy. Here skin sparing, skin is not excised, leaving the skin. They put an incision around the nipple and areola and then like this. So hence the name keyhole mastectomy. If this is a breast and this is nipple, they will put an incision like this. Hence it is named as keyhole mastectomy. Here skin is not excised, hence the name skin sparing mastectomy. So when are they indicated? If the tumors are centrally located or multicentric and it is extensively intraductal. So excision of nipple areola complex with minimal skin removal, that is this much part of the skin is only removed. So various approaches, but does not affect the recurrence rates. Okay. So what are the complications of modified radical mastectomy or basically mastectomy in general? So injury or thrombosis of axillary vein is most common. Other than that, seroma formation is the most dreadful complication. Hence we are putting drain after surgery. Okay. After that, there can be shoulder dysfunction if some nerves are injured during the surgery, and then pain and numbness will be common in any surgery. Flap necrosis, if we insert a flap after removal of breast, like a tram flap or LD flap, there can be flap necrosis or infection. Okay. If there is a flap rejection, then this is a possible complication. After that, lymphedema is a possible complication. If axillary nerve is injured, winging of scapula might happen. Pectoral muscles atrophy, like if the medial pectoral nerve and lateral pectoral nerve are damaged, then these muscles won't perform their action, and hence there will be atrophy of these muscles. Again, thoracodorsal nerve, serratus anterior, abduction of upper arm and all might be possible. Stewart-Travis syndrome, in which this is also known as lymphangiosarcoma. So what happens in this condition is, usually when we perform mastectomy with axillary clearance, there happens to be lymphedema as a complication. So once this lymphedema is prolonged for about 3 to 5 years, then it converts into a tumor, that is lymphangiosarcoma, which is malignant tumor. Because of this, we will have to go for amputation of the limb. Usually this is like upper limb will be swelling like elephantiasis. Okay, so this is because of breast tumor. So when the patient has undergone mastectomy with axillary clearance, during that some lymph nodes might have got damaged because of this, or basically we will remove all the lymph nodes. So whatever the lymph is there, that will be accumulating here, and that will lead to lymphedema. After that, it converts into a tumor. So that is lymphangiosarcoma, which is called as Stewart-Travis syndrome. Okay, because of this, again we will have to amputate the upper limb. Other than this, there is a procedure called as prophylactic mastectomy, which is nothing but mastectomy before even the disease progresses. This is done in case of in situ carcinomas like ductal carcinoma in situ or lobular carcinoma in situ, and it can be done in individuals with like we'll come to know that they are at high risk because their first degree relatives will be having breast carcinoma. So in that all conditions we will perform prophylactic mastectomy. So this was about surgeries like breast conservative surgeries. After that, one more method to control the local spread of the disease is radiotherapy. So in radiotherapy, again there are various types. You most commonly used for breast cancer is external radiotherapy. Usually total dosage is 5000 centigrades units and 200 centigrade units daily dosage 5 days a week for 6 weeks usually. Okay, so ಹೆಂಗೆ ಕೊಡ್ತೀವಿ 200 centigrade for 5 days in 1 week ಆಯಿತಾ. ಈ ಥರ 6 weeks. ಸೊ 1 ವೀಕಿಗೆ 1000 ಆಯಿತು. ಈ ಥರ 6 weeks ಕೊಟ್ಟರೆ 6000 ಹತ್ರ ಆಗುತ್ತೆ. ಓಕೆ, ಸೊ ಟೋಟಲ್ ಡೋಸೇಜ್ ಅಷ್ಟು ಹತ್ರ ಬರುತ್ತೆ. ಓಕೆ, ಆಫ್ಟರ್ ದಿಸ್ in order to promote the improve the prognostic factor and help the patient survive longer time, we can also use systemic therapy, which includes hormone therapy. Again, this is basically used for treating ER and PR positive tumors, which we had discussed. For any tumor which is ER and PR positive, for all age groups we can use hormonal therapy, which includes estrogen receptor antagonist like tamoxifen. Other one, progesterone receptor antagonist like medroxyprogesterone acetate, that is DMPA, which is a dose of 400 mg. Okay, oral aromatase inhibitors can be used, which is used in usually postmenopausal women, because aromatase will be more in case of postmenopausal women. So we will have to inhibit that in order to obtain benefits. So oral aromatase inhibitors usually used in case of postmenopausal women. Other than that, aminoglutamide, which blocks the synthesis of steroids. Because of this, again, pregnenolone will be inhibited. Okay, so LHRH agonists, sorry. So which acts like LHRH agonist. Because of this, again, this is nothing but medical oophorectomy. Basically, we are stopping estrogen exposure to the patient. So because of that, again, we all know because of increased estrogen exposure only breast carcinoma is happening. So by all these hormonal treatment, we are making sure that the patient is having less amount of estrogen, so that there is decreased breast cancer development. Okay, so what is the dose of tamoxifen? Again, this is an anti-estrogen or estrogen receptor antagonist, usually 20 mg dose. So this blocks the cytosolic estrogen receptors. How is the dosage given andre 10 mg BID or 20 mg OD. This is given for 5 years. Okay, its half-life is 7 days. So 4 weeks minimum is required to show its benefits, and it is used in all age groups. So letrozole, it is a aromatase inhibitors which is used in postmenopausal women. The dose is 2.5 mg once daily, and again this is also given for 5 years. Usually what is the combination we use andre, for 2 years we'll give aromatase inhibitors, and for 3 years tamoxifen. Okay, itara. Other than that, there is a monoclonal antibody being developed for breast cancer, that is trastuzumab, which blocks HER2 or new receptors. So because of the dosage being 4 mg per kg loading dose and then 2 mg per kg maintenance dose. So this is an upcoming drug. Okay, after that there is one more monoclonal antibody being developed, that is zapatinib. Again, this is a dual HER2 new receptor and EGF receptor inhibitor. Because of this, since this crosses blood-brain barrier, it is better. Okay, and the dose being 1250 milligrams OD. Yeah, there are various regimens being followed as a chemotherapy. Okay, so that is CIF, that is cyclophosphamide, adriamycin, and 5-fluorouracil. CMF, again cyclophosphamide and 5-fluorouracil are same. Methotrexate is used instead of adriamycin. CEF, again cyclophosphamide and 5-fluorouracil, epirubicin being used. TEAC is another regimen where drug resistant idre, in case to cyclophosphamide and 5-fluorouracil, we can use taxanes, adriamycin and cyclophosphamide. So okay, 5-fluorouracil ಗೆ drug resistant idre. Other combinations again being trastuzumab like monoclonal antibodies. So various types of chemotherapies are there. That is adjuvant chemotherapy andre this is a chemotherapy which is given after surgery. Okay, neoadjuvant andre before surgery we'll give this chemotherapy or cytotoxic drugs so that there is regression of the size of tumor. After that we will do surgically excising the smaller part of the tumor. So neoadjuvant andre before surgery we will give the chemotherapy. Adjuvant andre after surgery we will give this chemotherapy. Okay. Other than that, again palliative therapy is given for metastatic tumors. Yeah. So one more point I had to make is the staging of the breast cancer. Like this is a staging. I'll explain you in it. Explain it to you in a while. Okay. So yeah. Now we have to study about ಇದು ನಿಮ್ಗೆ ಎಷ್ಟು ಇಂಪಾರ್ಟೆಂಟ್ ಏನು ಕತೆ ಅಂತ ಗೊತ್ತಿಲ್ಲ ಬಟ್ ಐ ನಮ್ಮ ಅಂದರೆ ಇನ್ ಮಾಡರ್ನ್ ಮೆಡಿಸಿನ್ ಮಾಡರ್ನ್ ಸರ್ಜರಿ ಇಟ್ ಈಸ್ ರಿಯಲಿ ಇಂಪಾರ್ಟೆಂಟ್ ಬಿಕಾಸ್ everything that is treatment everything depends on this staging of breast cancer. Just a second. Yeah, so just like any other tumors, staging of breast cancer again it depends on T and M staging, that is tumor, lymph node and metastasis. So T is divided as T1, T2, T3, T4A, T4B, T4C and T4D. Okay, so this is most important, hence I have not pasted any picture and just highlighting it over there. I am trying to take some time and explain you this. Okay, so T1 is if the tumor is small and it is up to 2 centimeter. So any size up to 2 centimeter the tumor is classified as T1. Okay, so imagine this is breast and this tumor is only of this size, so it is up to 2 centimeter. Then if the tumor is more than 2 centimeter but up to 5 centimeter it is classified as T2. It is a simple classification, we need to remember this. Okay, if the tumor is more than 5 centimeter it is classified as T3. Okay, now T4A, this tumor now starts coming out of the breast. Okay, so it can go deeper and it can involve chest wall. Now the breast has, the breast cancer has started invading and it has extended to chest wall. Okay, what we need to remember is the chest wall doesn't include ribs, intercostal muscles and serratus. It includes these three things. Pectoralis major and pectoralis minor are not a part of chest wall. Okay, so if the tumor has spread to pectoralis major or pectoralis minor it doesn't come under T4A. If it involves chest wall, mainly ribs, intercostal muscles and serratus anterior, only then it is classified as T4A. After this, T4B is if it has progressed outwards and it has led to ulceration of the skin, or it has led to pudy orange appearance or poudy orange appearance, or if there are satellite nodules. Okay, and all these changes are limited to same breast, one day breast. Okay, so first T4A was the tumor was going into depth and involving chest wall. Now it has come up and involved the skin like ulceration, poudy orange appearance and satellite nodules. Then it is classified under T4B. T4C is both, like it has involved chest wall also, that is T4A, plus it has created an ulceration also, that is T4B. Then it is said to be T4C. And T4D being inflammatory breast cancer. Okay, so this is T, that is staging of breast cancer. Now coming to N staging. So N is again classified as N1, N2A, N2B, N3A, N3B, N3C. So basically N1 has 1, N2 has 2 columns, N3 has 3 columns. You can remember it this way. Okay. So N1 ಅಂತ ಯಾವಾಗ ಹೇಳ್ತೀವಿ ಅಂದರೆ if the metastasis is to ipsilateral axillary lymph nodes. So just like we know, breast cancer can spread to axillary lymph nodes. After that, intermammary lymph nodes and supraclavicular lymph nodes. Okay. So based on this, again staging is done. If it has spread to same sided axillary lymph node, then it is said to be N1, and provided here again it involves only level 1 and level 2 lymph nodes, and these lymph nodes are mobile. So N2A metastasis is to same ipsilateral axillary lymph node, level 1, level 2, but these lymph nodes are not mobile, they are matted or fixed. That is N2A. N2B is the tumor has spread to internal mammary nodes. Okay, so this one is done, this one is done. Okay, now N3A. It is metastasis to ipsilateral infraclavicular lymph node. Okay, if the tumor has metastasized to ipsilateral axillary plus internal mammary, then it is N3B. N3C is ipsilateral supraclavicular. What we have to note down is every node is ipsilateral. If the tumor has spread to other sided axillary lymph node, then it is considered to be metastatic. Okay, so metastasis agide andre it will be under M1. If there is no metastasis, M0. Simple. Okay, so based on this knowledge, they have staged the breast cancer. So proper staging ಬಂದು ಇವಾಗ ಬರುತ್ತೆ, that is staging. ಸ್ಟೇಜ್ 1 ಅಂತ ಯಾವಾಗ ಕರಿತೀವಿ ಅಂದರೆ ಟ್ಯೂಮರ್ 1, T1, N0, M0 ಅಂತ ಅಂದ್ಕೊಳ್ಳಿಬೇಕಾದ್ರೆ. ಸೊ ದಟ್ ಈಸ್ ಇಫ್ ದ ಟ್ಯೂಮರ್ ಈಸ್ ಜಸ್ಟ್ less than 2 cm, then it is stage 1 of breast cancer. Stage 2 of breast cancer ಅಂತ ಯಾವಾಗ ಹೇಳ್ತೀವಿ? T0 to 1, N1 or T2. That is, if the tumor is less than 2 cm, if the tumor is detectable or less than 2 cm and it has spread to ipsilateral axillary lymph nodes and the lymph node is mobile, okay, then T01, N1. Or if the tumor is more than 2 cm and less than 5 cm, in this condition we say it is stage 2. Okay, next stage 3. Stage 3 is T2, N1 or T3. Okay, so T2, N1 andre again tumor is between 2 to 5 cm and axillary lymph node involved is ipsilateral axillary lymph node, level 1 and level 2, but it is mobile. So T3 andre tumor is more than 5 cm. Stage 4 or again stage 3 is divided as stage 3A, stage 3B ಈ ಥರ. ಓಕೆ, ಸೊ ಇವಾಗ ನಾನು ಹೇಳಿದ್ದು ಓಕೆ ಯಾ ಐಮ್ ಸಾರಿ, this is stage 2B. Stage 2 ಇಂದನೇ they have started bifurcating. So this is stage 2A, this is stage 2B. Now stage 3A. So stage 3A ಅಲ್ಲಿ ಏನಾಗುತ್ತೆ, T0 to 2, N2, T3, N1 to N2. So in this condition again tumor might be of less than 2 cm or up to 5 cm and it is involving axillary lymph nodes. It may be mobile or matted. ಅಷ್ಟೇ. Okay, in that condition again it is classified under stage 3A. Similarly stage 3B ಅಲ್ಲಿ it is T4N0 to 2. So tumor is inflammatory breast cancer, or it may be involving chest wall, or it may be involving skin. And lymph nodes, again ipsilateral axillary group of lymph nodes or internal mammary lymph nodes, axillary group being matted. This is stage 3B. And again stage 3C is T any. It can be T1, T0 to T4 and N being 3. N3 andreno, it is spread to ipsilateral infraclavicular or both axillary and inframammary, internal mammary, or ipsilateral supraclavicular. So any, irrespective of the size of the tumor or anything, if there is N3, then it is classified under stage 3C. Stage 4 being if it has metastasized, that is M1. Stage 4 T any, M any, N any, M1. So this is stage 4. So why is this staging important andre? Okay, before that let me tell you a trick to remember this. So remember stage 1, so adding 1 N, T, N, M, adding everything will sum up to 1. Okay, in case of stage 2, 2A, adding if T1, N1, sum will be 2, T2 again 2. Okay, in case of stage 2B, adding summation will be equal to 3. 3A and 3B, 3A ali it will be equal to 4. Okay, so T3 iddu N1 irutte usually, so again 4. Stage 4 3BL it is almost 4 plus something. Okay, so this we can remember, and this also we can remember. So till here it is like 1 2 3 4. We just have to remember that there is only one stage 1, 2 parts in stage 2 and 3 parts in stage 3. Based on this we can easily remember the classification or staging of the breast cancer. So this staging, like ivaga suppose if any of the patient tells you, okay, I have been diagnosed with stage 2 breast cancer, this is what she is speaking about. Okay, so stage 2 breast cancer andre you will have to think that okay, stage 2A or stage 2B, two possibilities are there. That is the tumor is about less than 5 centimeters and 1 or 2 lymph nodes are involved, like that. Okay, so that is what actually staging is. So based on this staging, treatment differs, hence we need to remember this. So if up to stage 2B we tell that it is a early breast cancer. Okay, after stage 2B, that is stage 3 and stage 3B, locally aggressive breast cancer ಅಂತ ಕರಿತೀವಿ. Okay, after that if it is stage 4, it is distant metastasis. Okay, so after this we need to know the treatment. Like for this early breast cancer, what is the treatment modality andre? For early breast cancer it is breast conservative surgery plus sentinel lymph node biopsy plus radiotherapy. Okay, so this is the treatment for early breast cancers. If suppose we can't perform breast conservative surgery, then we can go for simple mastectomy. Okay, for locally aggressive breast cancer, that is 3A and 3B or 3C also, for this it is neoadjuvant chemotherapy first. That is before surgery we will have to give neoadjuvant chemotherapy like CAFO, CMFO, ಯಾವ್ದು ಬೇಕಾದ್ರೂ ಆಗ್ಬೋದು, ಯಾವ ಎನಿ ಥೆರಪಿ ಟ್ಯಾಕ್ಸೈನ್ಸ್ ಯೂಸ್ ಮಾಡ್ತಿರೋ ಏನು ಬೇಸ್ಡ್ ಆನ್ ದ suitable conditions. So neoadjuvant chemotherapy ಕೊಟ್ಟು once the tumor size regresses, then we will go for modified radical mastectomy, that is removing the breast tissue as well as level 1, level 2, level 3 group of lymph nodes. After this again we will give radiotherapy. Okay, so in case of distant metastasis it is just palliative therapy, and then we can give hormonal therapy to these patients. Okay, so this is the entire roadmap to treatment of breast cancers. So if we know exactly the staging, we can treat the patient aram se. Okay, yeah, so I guess I have covered most of the things about breast cancers. If there are any doubts, you can ask.